So good morning, everybody. Welcome again to the Up-to-Date in Hepatology Bucharest course 2019. It is the 6th annual meeting of the Romanian Community of Hepatologists. It is organized by the Romanian Association for Liver Diseases and Romanian Society of Gastroenterology and Hepatology, Fundent Clinical Institute, and the Carol Davila University in Bucharest. So extraordinary advances in hepatology have taken place recently, advances that impact clinicians' ability to diagnose and treat the most common liver disease. Highly effective direct-acting antivirals for hepatitis C and B have been developed and are continuously refined. The pathophysiology of non-alcoholic liver disease and fibrosis is now better understood, and it's setting the foundation for the development of new effective therapy. Then new approaches have emerged in the management of complication of liver cirrhosis, and new innovative therapeutic concepts assist the clinician in the fight against liver cancer. With the subject from theory to practice in liver disease, this year's meeting will be focused on the integration of the latest advances at the front line of hepatology into daily clinical practice. We have organized this 2019 meeting in the form of 6 plenary sessions, carefully selected around relevant topics for practicing hepatologists, and also new topics in the core program this year will be 2 sessions, the session of pregnancy and liver disease and endohepatology, or optimizing endoscopy approach in patients with cirrhosis. Then 2 state-of-the-art lectures will target the persisting challenges on the road of elimination of hepatitis C and acute or chronic liver failure in 2019. Then a hands-on workshop of ultrasound elastography, and the second one focused on the role of biomarkers in assessment of liver fibrosis will be the integral part of this year program. And please register timely for this workshop as the number of participants are limited. In addition, the Satellite Symposia section will complement this scientific program, offering a quick exposure to the state of the research in the industry. The educational objective of this year's course, as usually, remains to deliver updated knowledge, to share opinions and clinical experience, to network, and to stimulate the implementation of an evidence-based approach in order to eventually improve the care of so many people suffering from liver disease in our country. Finally, I would like to thank all those contributing to the 2019 meeting, the faculty, the organizing institution, our generous corporate supporters, and last but not least, to you, the participants, who give purpose to our educational event. And please join the Romanian Association for Liver Disease. It is actually a newborn associated, 2 years old. Become a member of the growing community of hepatologists in our country, getting involved in our project and helping us in our medical and social mission. We offer you a growing number of advantages in exchange to your membership, as you can see outside at the desk. And finally, I hope you will enjoy the meeting, the location, which is the cultural, historical, and scenic vibes of Bucharest in spring. I hope you will learn a lot, interact with experts and colleagues, building further collaboration. And with this, I wish you a fruitful meeting, and I already invite the chair of the first session to start the meeting. Thank you very much, and welcome.
Good morning, everybody. It's an honor and a pleasure to be here again at the 6th edition of Up to Date in Hepatology Bucharest. And I would like, on behalf of Romanian Society of Gastroenterology and Hepatology, to welcome you all and to congratulate Liana Gheorghe, the director of this course, the engine of Romanian hepatology for the last 10 years. I now invite the first speaker of this session, a very well-known hepatologist, Romanian hepatologist, Bogdan Procopescu. He will speak about anticoagulation therapy in liver cirrhosis, a very challenging subject. Please, Bogdan.
Thank you very much for the kind introduction, and I would like to thank for this invitation. It's really an honor for me to start the most important hepatology meeting in Romania. And also I would like to thank for this very challenging topic. So, anticoagulation in cirrhosis. Before discussing what are the therapeutic options for anticoagulation, I would like to stay a few moments with you to discuss a little bit about particularity of coagulation in patients with cirrhosis. As you all know, the hemostasis is a very complex process which implies primary hemostasis, where the principal actors are platelets and von Willebrand factor, coagulation, which is continuing with coagulation, where coagulants but also anticoagulant factor are very important, and finally fibrinolysis. The primary hemostasis begins when the endothelial, I don't know if I have a pointer, the endothelium, its continuity, it's disrupted, and then von Willebrand factor will attach the platelets, and like this will form the first clot. What is important is that the von Willebrand factor, it's cleaved by Adams 13, which is secreted by the liver, and also its decrease in liver diseases. The main changes in cirrhosis are, as you all know, low platelet counts, that it's probably due to hypersplenism, but also to decreased thrombopoietin, which is secreted by the liver. But also there is an increase in von Willebrand factor, which is due to endothelial dysfunction, but also because the enzyme Adams 13, it's decreased. Well, also the fibrinolysis, it's modified, and there are changes that promoting bleeding, like decreasing in alpha-2 antiplasmin or factor 13, or also modification that promote thrombosis, like decreasing plasminogen. I let the most important part of coagulation at the end, because you all know the two ways to activation of the coagulation, the extrinsic and intrinsic pathway, which finally leads to thrombin generation, which transform fibrinogen into fibrin. But what is important, and I would like to draw a little bit attention about the mechanism of contrabalancing this coagulation cascade. Under the action of thrombomodulin, protein C will be activated, and together with protein S will affect the factor 8 and factor 5. Also, antithrombin 3, it's important to counterbalance the coagulation. Now, what happened in cirrhosis? We all know that coagulation factors secreted by the liver are decreased in liver diseases. You have here the list of the main factors. But also, protein C, protein S, and antithrombin are decreased. And the factor VIII, which is secreted by the endothelium, it's increased in patients with cirrhosis. How can we count this modification? Well, in clinical practice, we all use the INR to see how the patient are at risk of bleeding. But we should know that the PT or INR, it's reflecting only the action of procoagulants factor and actually assess only the first 10% of the thrombin generation. So it's not an appropriate test to test the entire process of the coagulation. Recently, endogenous thrombin potential with or without thrombomodulin, it's a test that it's counting the entire process of the coagulation, and especially it's also by adding thrombomodulin, which activate protein S, may help to assess also the anticoagulant, natural anticoagulation path. This was used by Tripodi in his very well-known study, where he compared a healthy patient with cirrhosis by this endogenous thrombin generation potential, and without thrombomodulin, we see that in healthy patient, the coagulation is much better, significantly better than cirrhotics. But when we add thrombomodulin, we see that cirrhotics and healthy patient have the same thrombin generation potential. More than that, if we look after adding thrombomodulin, we see that healthy patients decrease their thrombin generation with almost 60%, while cirrhotic patients only 38%. And that means that cirrhotics are relatively resistant to protein S. The same group of authors demonstrated this, that when they calculate the ratio of thrombin generation with or without thrombomodulin, we see that this resistance to protein S increase with the severity of the disease. And actually, patients with Child-Pugh C score have more resistance than even the patient with congenital protein C deficiency. And this is due to an increase in factor VIII and a decrease in protein C. Therefore, this patient might have a status of procoagulant status, and it is demonstrated clinically, but an increase in portal vein thrombosis in patients with advanced disease up to 25% in decompensated. In a study, the largest study up to now, which included 700 cirrhotic patients, the prevalence of portal vein thrombosis was 11%, and we see that this prevalence increased in advanced stages. We know that beside procoagulant modification in cirrhotics, the portal flow has also a significant importance. So with increase in portal hypertension, the portal flow, it's decreasing, and this is also a risk factor for developing portal vein thrombosis. The relevance of these events, well, it's a matter of debate. What we know for sure, that portal vein thrombosis has potential impact in transplantation. And probably this is the main well-demonstrated issue. Apart from portal vein thrombosis, patients with cirrhosis have also a risk of systemic thromboembolic events. And in this meta-analysis, which included a very large number of patients, we see that cirrhosis is a risk factor for venous thromboembolism, deep vein thrombosis, or pulmonary embolism, and you have here the odds ratio risks. Therefore, in this context, what are the indications for anticoagulants in cirrhosis? Regarding the portal vein thrombosis, the latest Baveno consensus guidelines recommends that patients that are candidates for liver transplantation should be anticoagulated, especially if the thrombosis regards the main portal trunk or if thrombosis is progressive. The goal is to facilitate the liver transplantation and to increase prognosis in patients with transplantation. Regarding the non-candidates for transplantation, there is no recommendation regarding anticoagulation treatment and could be considered in selected cases. What treatment should be used? The recommendation based on evidences, although you see the evidences are 5D, so more expert opinion, so the options are low molecular weight heparin or vitamin K antagonist. And there is no really much data about direct oral anticoagulants. Apart from portal vein thrombosis, patients with cirrhosis may have comorbidities that could need anticoagulation. These are the classical indication for anticoagulation in cardiology wards. Well, regarding the options, vitamin K antagonists are efficient, but they need monitoring by INR. And we don't know for sure how can we do this in advanced stages. Regarding the unfractionated heparin, also need monitoring, but is usually used in the inpatients setting. It's difficult to monitor, and it also has problem with the heparin-induced thrombocytopenia, the risk for that. Low molecular heparins are proved to be efficient, also can be monitored by anti-factor 10 activity, although this is not used usually in clinical practice. It's certain scenario like renal failure or in pregnancy could be useful, and I'm wondering if in advanced stages of cirrhosis this is not also important. And the direct oral anticoagulants, really the main drawbacks is that we don't have enough evidences. What is the effect of anticoagulants in patients with cirrhosis now that we know what are the main changes in the coagulation? Well, this is a very important study that compared healthy patients with compensated cirrhotics, patient with decompensation, and patient with acute or chronic liver failure. And they looked at the thrombin generation, so with thrombomodulin. So they looked at the entire process. Well, and they compare the two direct oral anticoagulants, rivaroxaban and dabigatran, and enoxaparin. We see that in compensated cirrhosis, there are not significant changes in comparison with all healthy control. But in patients with decompensated cirrhosis and acute liver failure, rivaroxaban, it's not very effective in comparison with the effect on healthy patients. But dabigatran it's too effective. You can see here that in patients with acute liver failure, actually they didn't generate thrombin anymore. And low molecular heparins, enoxaparin, it's a little bit more efficient than in healthy controls or compensated cirrhosis. What is the clinical effect? And this is a recent meta-analysis of the use of anticoagulants, and here were compared low molecular weight heparin and warfarin regarding the complete recanalization. Anticoagulant, it's efficient. Regarding progression of portal vein thrombosis, anticoagulant treatment, it's protective. While regarding the bleeding, there is no difference between patients with anticoagulant and without anticoagulant. But when you look at specifically at variceal bleeding, actually anticoagulant treatment has a protective role. And this is probably another brick in the wall of debate if the portal vein thrombosis has or not impact on prognosis of patients with cirrhosis. When they looked at the type of anticoagulation, although there is no difference between warfarin and low molecular weight heparins, it looks like the latter has a better effect on recanalization and also for protection from variceal bleeding. There really not much data about the survival of patients with anticoagulants. This is one of the recent study that proved that anticoagulant treatment conferred to this patient a better survival, and it's independently associated with survival together with the Child-Pugh score. Regarding the prevention of portal vein thrombosis, this is also a very well-known study of Erika Vila that demonstrated by adding enoxaparin in a patient without portal vein thrombosis, actually you may prevent occurrence of portal vein thrombosis. And what is interesting, you may prevent decompensation in this patient, and also the patient with anticoagulant treatment has a better survivor. Regarding the other indication for anticoagulant treatment, there are few studies that prove, and this meta-analysis proved that anticoagulant treatment for atrial fibrillation in cirrhosis is efficient in preventing stroke. And when you look at the risk of bleeding, although it's a little bit increased in comparison with no anticoagulation, it's really non-statistical significant. A very recent study proved the same concept, that what is interesting is that here we have many patients treated with the new anticoagulants. And regarding the ischemic events, there is no difference between the new anticoagulants and warfarin. No difference in terms of intracranial bleeding, but regarding major bleeding and major GI bleeding, it seems that the new anticoagulants are more safe. Well, it should be before, although the number of the patients it's impressive, it should be highlighted that the study was designed retrospectively, and the patients were diagnosed based on their diagnostic codes. So there is no data about the liver disease, how severe was, and therefore should be taking just as it is, and not believe too much this data, because on the new anticoagulants drugs, really there is too few data. These are the existing study. You can see limited number of patients, and although this is a systematic review, there is no really big data to review. We can see that regarding the bleeding in one series was up to 15%. Yes, this is the last slide. What we know that vitamin K's antagonists are safe. Also, low molecular heparin, it's also efficient, so probably are the best options for this patient. And don't forget about the concept of anticoagulation, that it's a myth. Thank you very much, and excuse me for...
Thank you very much for this, well, very interesting talk. We have time for one short question.
So, Irina, please.
My question is, you said that the patients with liver cirrhosis also different thrombosis. It's not working. It's working? Do you recommend primary prophylaxis for deep vein thrombosis in those patients, especially in patients with hepatic encephalopathy or patients with severe ascites, that these patients have a low mobility rate, they stay a lot in the bed, especially during hospitalization. So do you recommend to do primary prophylaxis for deep vein thrombosis?
Thank you very much for these very good questions. Actually, there is no data on that, but based on all the evidences that we have, I think that in patients with low mobility, we should consider primary prophylaxis, especially maybe compressive technique that is it's safer than maybe anticoagulant treatment, but it should be considered.
Okay, thank you.
Thank you very much. Is any other question? If no, it is my pleasure now to invite Sola Elsa to speak about albumin in liver cirrhosis.
Well, good morning, everyone. First, I'd like to thank the organizers for their kind invitation to participate in this meeting, and it is a pleasure for me being here in Bucharest. So my talk today is about albumin in liver cirrhosis. Is this one? Oh, no. This one. Okay, so I have divided my talk into these three different sections. So first I will briefly discuss the main characteristics of albumin as the molecule. Then I will summarize the classical indications of albumin in liver cirrhosis. And finally, I'd like to focus on the results of very recent studies that suggest a new indication for the use of albumin in patients with decompensated cirrhosis. Sure.
The second one should be that.
Ah, no, over there. Oh, no, it's okay. Over there. Okay, now want to go back. Okay, so basically, albumin as a molecule, so it's a very, it's a very flexible molecule, but it's also very stable, and it is divided into three domains of a very similar size. And what is important in this albumin is that besides it has intradomain disulfide bonds that it makes it a very stable molecule, it also has a free cysteine here that this gives to albumin an antioxidant effect that we will see. It's also important for patients with, when we use albumin for patients with cirrhosis. The main functions of albumin rely on the ability of this molecule to bind a very wide range of ligands, both endogenous and exogenous ligands, to transfer them to other tissues and organs and to increase their solubility in plasma. So as you can see in this plot, albumin has many different effects. Traditionally, or the main effect of albumin has been attributed to albumin as a plasma volume expander. Due to its appropriate molecular mass and because it has a negative charge, albumin has a high oncotic pressure, and this gives to albumin the attribute of being a very high volume expander. However, albumin has these many other properties, and what is important specifically for patients with cirrhosis is that albumin is able to bind lipopolysaccharide and other bacterial products, also reactive oxygen species, nitric oxide, and prostaglandins. And through these functions, albumin is able to modulate an inflammatory reaction. And as we saw before with this free cysteine, albumin also has an antioxidant property. So through these properties, immunomodulation and antioxidant, it is also thought that albumin is important as treatment for patients with cirrhosis. We'll see here the main rationale for using albumin in patients with cirrhosis. So as you all know, circulatory dysfunction is the main player in the pathophysiology of cirrhosis and the development of complications, mainly ascites, hepatorenal syndrome, hyponatremia. And this circulatory dysfunction is characterized mainly by this effective arterial hypovolemia, which is as a consequence of a very marked splenic arterial vasodilation. However, in the recent years, there is growing evidence that in patients with cirrhosis, there's a chronic systemic inflammation that also plays a role in the development of complications of cirrhosis. So bacterial products or bacteria coming from the bacterial translocation and also products coming from the injured liver, from the hepatocytes or the injured cells can activate circulating immune cells and generate this systemic inflammation that also plays a role in the pathophysiology of the disease. So classically, we have been using albumin, and the effect of albumin on liver cirrhosis, we thought it was mainly due to its effect as a plasma volume expander, counteracting this effective arterial hypovolemia. However, we know that albumin is also an immunomodulator, and it has antioxidant effects. So now it is thought that albumin can also act in decreasing or counteracting the systemic inflammation that exists in patients with cirrhosis. So which are the classical indications for albumin in cirrhosis? Albumin has been used as a treatment long ago in patients with cirrhosis, and the main three indications for albumin in cirrhosis are preventing post-paracentesis circulatory dysfunction in patients undergoing large volume paracentesis, preventing type 1 hepatorenal syndrome in patients with a spontaneous bacterial peritonitis, and the treatment of type 1 hepatorenal syndrome. It has not been demonstrated that albumin is effective in patients with bacterial infections other than spontaneous bacterial peritonitis. And I will just briefly discuss these main three indications. So you know that post-paracentesis circulatory dysfunction syndrome is a further impairment of circulatory dysfunction occurring in patients who undergo large volume paracentesis, specifically without albumin. And this syndrome is characterized by a marked increase in plasma renin activity, which is associated to complications such as hepatorenal syndrome, hyponatremia, and it is also associated to a high mortality. So these are results from a randomized controlled trial from many years ago, where they compared patients undergoing large volume paracentesis with or without albumin. And as you can see here, that those patients who did not receive albumin presented a marked increase in plasma-renin activity after the paracentesis, reflecting an impairment of circulatory function, and those patients who received albumin did not present this increase in plasma-renin activity. And this was associated to a decrease in complications, and as you can see here, those patients receiving albumin presented a significant decrease in the incidence of renal failure and hyponatremia. With respect to spontaneous bacterial peritonitis, we also know from many years ago that albumin is effective in those patients, and this is a randomized control trial from many years ago that demonstrated that the association of albumin to antibiotics decreased the incidence of hepatorenal syndrome in patients with SBP from about 30% to 10%. And this was associated also to a significant decrease in mortality, that patients receiving albumin together with antibiotics had a significantly better survival than those patients not receiving albumin. And finally, we also all know that the treatment of choice for patients with type 1 hepatorenal syndrome is the combination of vasoconstrictors, specifically terlipressin and albumin. And it is known that those patients receiving vasoconstrictors alone have a lower rate of response compared to those patients receiving terlipressin or vasoconstrictors plus albumin. These are also results of a randomized trial from many years ago that compared patients with type 1 hepatorenal syndrome treated only with terlipressin or with terlipressin plus albumin. And you can see here that those patients receiving only terlipressin serum creatinine levels did not decrease significantly, and however, those patients receiving terlipressin together with albumin presented almost all of them a significant decrease of serum creatinine and a resolution of hepatorenal syndrome, and this was also associated to an improved survival, so that those patients receiving terlipressin and albumin had a better survival compared to those patients receiving terlipressin alone. So these are the main indications of albumin in cirrhosis so far and that we all know. And now I'd like to focus on results of two recent trials that were published just last year, almost in parallel, and that they suggest or they investigated a new indication of albumin in patients with decompensated cirrhosis, and the goal of these two trials was to assess the effectiveness of giving albumin or long-term treatment with albumin on patients with decompensated cirrhosis, not for specific complications, but to try and decrease the progression of the disease, decrease the incidence of complications of cirrhosis, and at the end improve survival on those patients. So this is the first trial, that it's called the ANSWER trial. And this is a randomized open-label trial that randomized around 400 patients to receive a standard medical therapy or to receive a standard medical therapy plus periodically intravenous albumin. And the dose that they gave albumin to those patients was 40 grams twice weekly during the first 2 weeks of the trial, and then 40 grams weekly for almost 2 years. So these were patients with cirrhosis and ascites, and these were outpatients with cirrhosis, and it has to be noted here that those patients with refractory ascites or those patients with renal failure were excluded from that trial. So these are the main results of the trial, and as you can see here, that those patients receiving a standard medical therapy plus a long-term albumin, which are the ones in red, presented a significantly better 18-month survival compared to those patients who received a standard medical therapy alone. And this was associated to a decrease in the incidence of almost all complications of cirrhosis. This is the incidence of infections, renal failure, hepatic encephalopathy, and the incidence of almost all complications decreased in those patients receiving a standard medical therapy together with albumin for almost 2 years. So in contrast to this trial, we have this other one trial that was published almost in parallel and that we conducted in our unit. And this was a randomized double-blind placebo-controlled trial where we administered intravenous albumin, a long-term intravenous albumin, in this case together with a vasoconstrictor, which is midodrine, and this was specifically in patients with cirrhosis and ascites awaiting liver transplantation. So in this trial, we randomized 196 patients to receive a standard medical therapy plus midodrine and albumin, or standard medical therapy plus placebo of both drugs. In this case, the dose of albumin was lower. We were giving 40 grams every 2 weeks to these patients, but we associated midodrine as a vasoconstrictor. In contrast to the results of the previous trial, in this trial we could not see any differences between the two groups in the incidence of any of the complications of cirrhosis, and we could not see any differences in survival in those patients. It has to be noted here that these were patients on the waiting list for liver transplantation, so although the treatment was planned to be a long-term treatment for 1 year. Of course, these were patients on the waiting list and were being transplanted during the trial, so in most patients the treatment had to be interrupted because they received a liver transplantation, and the median duration of treatment for those patients was 3 months. We could not see differences on the incidence of complications, but when we investigated vasoconstrictor activity in those patients by plasma renin activity and aldosterone, we could see that those patients receiving treatment with midodrine and albumin, which is the green line, had a significant decrease on the activity of plasma renin activity during treatment and a significant decrease in aldosterone levels during treatment. So this suggests that treatment was associated with a suppression on the activity of these endogenous vasoconstrictor systems, but probably this suppression was not enough to decrease the progression of the disease and to decrease the incidence of complications and to decrease survival. So these are two very similar trials, but they have their differences and results are completely different. So this deserves a bit of comment. And this table compares the main characteristics of the two trials and try to explain why results are so different between these two trials. So first, the MATCH study, which is the one that associated albumin and midodrine, randomized 196 patients, less than the other trial, but these were specifically the population with cirrhosis and ascites awaiting liver transplantation. And the other study randomized more than 400 patients, and these were cirrhosis and ascites, but these were outpatients and excluded patients with refractory ascites. Then, as you can see here, by the levels of bilirubin and MELT score, the patients included in the MATCH trial had a more advanced liver disease compared to patients from the ANSWER trial. And although we cannot know that, but maybe we could speculate that maybe in those patients with more advanced liver disease, albumin or treatment may be less effective than in patients with less advanced liver disease or these outpatients. One of the other major differences that could, of course, play a role is the dose of albumin. Patients from the MATCH trial received a lower dose of albumin, which was 40 grams every 2 weeks, and patients from the ANSWER trial received 40 grams weekly, together with a loading dose at the beginning of 40 grams twice a week. The MATCH trial associated another treatment, which was midodrine, which is a vasoconstrictor, but this dose from the MATCH trial was not associated to a significant increase in plasma albumin levels, and dose from the ANSWER trial was associated to an increase in plasma albumin levels in those patients during the study. So it can be that the dose used here in the MATCH trial was not enough to increase plasma levels of albumin and to generate an effect on those patients. But it has to be also taken into account that giving albumin to these patients weekly or twice a week is associated that these patients have to come to hospital or to day hospital or whatever, every week or every 2 weeks, that this also generates an economic burden and also a social burden and an impact on quality of life of those patients. And finally, the last difference here is that Well, the MATCH trial was a double-blind study that we used placebo of those drugs. The ANSWER trial was not blinded, so that patients on the treatment group received albumin weekly. So this means that patients had medical controls weekly at the hospital, and patients from the standard medical therapy had no control, so they had their normal controls. So this includes an inherited bias, I think, that is that patients on the treatment group had more medical controls and were more controlled than patients from the other group, and this could also have an impact on the outcome. However, I think that these results from those trials open a very important debate, and probably we need to think on start giving long-term treatment with albumin to patients with decompensated cirrhosis, but probably we need to think, or we need to select which is the population of patients that are going to benefit from this treatment, and which is the dose of albumin, and if we need to target, for example, a specific level of plasma albumin to reach so that treatment can be effective. So just to summarize, these are the recommendations of the last and very recent EASL clinical practice guidelines with respect to this treatment. These trials were published very few time before these guidelines were published, and this is what they suggest. So they say that the strategies based on targeting long-term albumin administration have shown a potential benefit on decreasing cirrhosis progression in patients with decompensated cirrhosis. However, further clinical trials research are needed to confirm the safety and the potential benefits of this therapeutic approach in patients with decompensated cirrhosis, and probably double-blind placebo-controlled trials would be ideal to have robust results on a treatment that, if we start giving this treatment to patients with decompensated cirrhosis, will change the paradigm, how we treat this type of patients. And finally, this is also a summary from an editorial that was published for one of these studies that I think that it is also very helpful as a summary. And it says that these recent studies have stimulated a huge interest in outpatient albumin treatment for patients with advanced liver disease, that this will probably lead to improvements in the management of these patients. However, further questions remain, particularly around the implementation of this treatment, and also the targeting of an optimal serum albumin concentration, and probably before targeting the specific or selecting the specific population before this treatment with albumin is adopted for all outpatients with decompensated cirrhosis. And this is all. Thank you very much.
Thank you very much indeed for this interesting presentation. The paper is open for discussions. If it is any question. Yes, Bogdan.
Thank you for this nice talk. I don't remember very well from your study how many patients had transplantation. Maybe transplantation has an effect on. I mean, how was transplanted patient regarded regarding the endpoint, the survival endpoint?
Yeah.
Was maybe transplantation had a competing effect on survival of this patient?
Yeah, this is a very good point, because I think that this is the main difficulty on performing this kind of trials in patients on the waiting list for liver transplant. So the percentage of patients that were transplanted was similar between the two groups, so there was no significant difference between the two groups. So we did not use a competing risk analysis for that trial, because the percentage of patients from both groups was very similar. However, you're right that the percentage of patients transplanted was very high in both groups, more than 50% at the end of the trial, because the rate of transplantation is high in our region. So this probably can have an impact. So probably the major conclusion is that maybe if you have those patients and you expect that they are going to be short time in the waiting list and they are going to receive this kind of treatment for a short time, which is 2 months, the median that they receive here, probably this treatment may not be effective because the treatment is not going to have time to generate an effect, and maybe we need to think on this kind of treatment for patients that can receive this treatment for a longer period of time.
Liana.
Very interesting. Thank you for the nice talk. I'm very interested if there are data or observations or studies in the literature looking at the correlation between albumin, long-term albumin administration, and the nutritional status of the patient. Because by preventing or correcting the complication of decompensated cirrhosis, it could be of interest that this patient have actually more appetite or limited restriction or so on, and so they may increase their nutritional status.
Yeah, this is another very interesting observation. So as far as I know, for specifically evaluating nutritional status, I think that there's no specific evaluation, but for this ANSWER trial, which is the biggest one, the only thing they can see is that there is a significant increase in plasma albumin levels, so that this could reflect maybe an improvement in nutrition, or at least in albumin. And the other thing is that they also evaluated quality of life on those patients, not specifically nutrition. And as far as I can remember, I think that there was a slight or a significant increase in quality of life on those patients. So this could also reflect, not specifically nutrition, but quality of life, yeah.
Yeah, thank you very much. But when we evaluated the sarcopenia with
Yeah.
the available method, could be an interesting one.
Yeah, sure. This is very interesting because now we know that sarcopenia has also probably a negative impact on those patients. So probably the future trials that investigate that should include nutrition as an endpoint, probably. Yeah.
Thank you. Did you have a minimum level of albumin, serum albumin, in inclusion criteria for patients on placebo? Because you spoke a lot about MELD and bilirubin, but you didn't mention at all the initial level of albumin for neither study.
Yeah, you are right. We did not have a level of albumin, a baseline level of albumin to include or exclude patients. It was only patients with cirrhosis and ascites, and there were no significant differences on baseline levels of albumin between the two groups. So in neither both of the studies, but there was not a level.
So even a very, very low level of albumin you included in placebo arm?
Yeah.
Because, a practitioner would have some, restraints to include a patient in a study with very, very low albumin when albumin is available, with or without guideline.
Yeah,
to support this.
Yeah, you're right. But in both studies, patients were randomized irrespective of the baseline levels of albumin, because this was a randomized controlled trial, and in fact at the end there were no differences between the two groups. But maybe with these results, maybe albumin concentration needs to be a target. So maybe in future studies this can be taken into account for sure.
Self the stand.
Okay, so next talk, which I think it's in a very challenging topic nowadays, is about the use of non-selective beta blockers in patients with cirrhosis.
Yes, I'm good. Okay. So to speak about non-selective beta blockers and portal hypertension, I think is an unavoidable subject in a hepatology course. So I will try to speak about status quo, about the challenges, might have a, it's all right, you have heard me? Yes, so about the status quo, the challenges, and of course, I will have a look to the future. This one, I guess it is. So, you can look here, 1981. This was the beginning with this paper, and please look, it was a controlled study, so we haven't spoke at all about randomized study at the beginning of beta blockers. With this paper done by Didier Lebrec and his team, we have started to recommend beta blockers in liver cirrhosis. Of course, the first indication was prevention of recurrent gastrointestinal bleeding. In the next decade, some other papers appeared, but please look again. It was not a randomized study. So more than that, the level of evidence was not too high. However, this kind of papers were the basis for the indication of non-selective beta blockers in liver cirrhosis. Today, we accept and we recommend all of us beta blockers in primary and secondary prophylaxis of varicose bleeding, and we know very well because some other studies appears, and if I would be very sincere, I can tell you that we are prescribing beta blockers because of, how to tell you, experienced studies, experienced medicine, and a little bit less about because of evidence-based medicine. It is known anyhow that the number needed to treat for prevention the first varicose bleeding is 6 in patients without ascites, and please, it is a slight difference, 11 patients in those with ascites. So if the patient have ascites, it seems that beta blockers are a little bit less effective in preventing the first episode of bleeding. Number needed to treat for prevention of the varicose bleeding recurrence is less, is 5, so beta blockers are even more effective in secondary prophylaxis. And number needed to treat for prevention 1 death is 13. I think we have enough data to say that beta blockers are very effective for preventing the second varicose bleeding, because it is the first time when we are speaking about prevention of death in liver cirrhosis with beta blockers. So we prevent 1 death treating 13 patients. It is a lot. Probably in this room are a lot of very young hepatologists which are in love with endoscopic methods. And some of you are very, prone to use varicose bending for preventing even first episode of varicose bleeding. Please look at the first side. You have the impression that endoscopic varicose ligation is better than propranolol, but pay attention, without any influence on mortality and without statistical significance. And it is needed a number of 33 endoscopies for preventing 1 bleeding episode. And if you look a little bit further, after 2 years of follow-up, patients who are taking propranolol, 11% are having 1 bleeding episode, 5% of those who are taking carvedilol, and 25% of patients who had an endoscopic varicose bleeding. Of course, a lot of facts are included in this analysis. Probably a part of the patients who had endoscopic varicose bending, they didn't follow up all the program for varicose ligation, and they still had some varices after 3 months, 6 months, and they did not repeat the endoscopy. When we are speaking about secondary prophylaxis, it is very well accepted that beta blockers plus ligation is the best treatment to be chosen. You probably know, all of you, this slide. The mortality, the recurrence of bleeding after the first bleed is very high if you are leaving the patients untreated, and if we use ligation plus beta blockers, you see the rate of recurrence is less than 20%. Of course, you might pay attention that we have 19 trials which have studied the bleeding rate in patients without treatment. We have only 5 trials who looked at ligation plus beta blockers. We know now, very well we know, that the essential component in combination therapy is not band ligation. It's represented by beta blockers. You can look here, it's not very good, I cannot use the pointer, but you can see, okay. You can see that the mortality in patients who are only receiving endoscopic treatment is much higher than the mortality in patients who received both beta blockers and endoscopic therapy. In this study, the same, the mortality in patients who received only endoscopic treatment is much higher than in patients who received both beta blockers and endoscopic therapy. I can conclude very easily that don't forget endoscopic therapy is not enough for preventing for secondary prophylaxis of varicose bleeding. So the beta blockers is the key element of combination therapy. We know even more than that, that probably these results are better in patients who are having a hemodynamic response to beta blockers. It is well defined now that the gradient has to be less than 12 millimeters mercury or to obtain a decrease in the gradient with 20%. And you can see there the shortcoming of beta blockers, only less than 50% of cirrhotic patients are responders to propranolol. What is the effect of this 50% responding to beta blockers? You can see here that responders are having less varicose bleedings than non-responders, are having less ascites, and survive more than non-responders. It is a meta-analysis which demonstrated the same in the patients who are responder to beta blockers, so who obtained the pressure less than 12 or a decrease of more than 20%, the varicose bleeding was significantly less than in patients who were not responders, and even more, the mortality was less, which is, I think, is a very important thing to keep in mind. The beta blocker administration is not very easy, but anyhow is not very hard. It is a pill. You should pay attention to use slow titration, to use the highest tolerated dose, to have a target, but to remember all the time that you cannot recognize very easily the hemodynamic responders because splanchnic vasoconstriction is due to beta-2 receptors and cannot be identified by cardiac frequency measurement. And it is another thing you should pay attention, and you might consider that you can recognize some hemodynamic responders, the absence of E4 tachycardia. This could be a marker for hemodynamic response. You have here a scheme how you can manage dose titration for propranolol. It is not standardized method, but you can use your own. I want you to remember that in advanced liver disease, the hepatic metabolism decreases and you need lower dose. So it is necessary to go and to see the patient from time to time and to adjust the doses of beta blockers. Of course, more than 30 years have passed since I have shown you the first picture over there. We are using beta blockers for 38 years now. It is normal in medicine that a challenge had appeared. I am appealing to another French hepatologist, Thierry Poinard, who had a very nice paper on truth survival in clinical research. And you can see here that half-life of truth was 45 years, and 20 years survival of the conclusions in meta-analysis 57%, in randomized trials 85%, non-randomized trials 87%, and if it was a positive conclusion at 50 years, the survival rate was 14%, and if it was a negative conclusion, the survival was 68%. I think in beta blockers we didn't have a randomized trial. We had a control trial. Maybe the beta blockers are a little bit luckier, but we had a positive conclusion, not a negative one, of those initial studies. But, you see, it is the challenges anyhow appeared. Maybe the most interesting fact about is the same Lebrec had challenged his initial papers. Of course, it is known in the literature as CERSTE study, but if you are looking very well, the last author, the senior author, was Didier Lebrec again. So 1981 and 2010. But again, it's not a very well-conducted study. It is an observational prospective study, and he demonstrated somehow that beta blockers in patients with refractory ascites could increase the rate of mortality. You can imagine what follows after this. A lot of papers, some of them, the initial one, demonstrated an increase of mortality in patients, in severe patients who were on beta blockers, but the papers became more and more, and the majority of them challenged again the hypothesis that beta blockers will have in all patients with refractory ascites and bad influence. So now you can see a lot of noise here, a lot of letters, a lot of papers. Everybody had an opinion about beta blockers and worse outcome related of their use. But you see the guideline. Until randomized trials are available, beta blockers should be reduced or discontinued if a patient with refractory ascites develop any of the following events: systolic blood pressure lower than 90, hyponatremia, or acute kidney injury. In the rest of the cases, beta blockers are used as before. We don't have high level of evidence about beta blockers, but we have a long history of using them in medicine and a lot of evidence that they save some lives and prevent at least some bleedings. Of course, there are limits. Less than 50% are hemodynamic responders. There are relative contraindications, there are side effects, it is a diminished adherence in time, so maybe we should look to something else. And we have looked at carvedilol, which is a beta blockers, but it has a mild anti-alpha-1 adrenergic activity. It had been used for treatment of arterial hypertension and heart failure. It is 2 to 4 times more potent than propranolol and has potential antioxidant activity, which might be important in patients with liver cirrhosis. Another problem of carvedilol is its vasodilating effect can enhance hypotension, and patients with liver cirrhosis do have hypotension, can enhance sodium retention and increase need for diuretics. So in patients with liver cirrhosis and ascites, we might be very careful when we think to use carvedilol. There are some papers, and I have chosen only one, who have shown the improved survival in patients with liver cirrhosis and ascites when we use carvedilol. What is important, and I would like to emphasize, is that the hemodynamic response is much better than in propranolol. You can see that 75% of patients with liver cirrhosis are responder to carvedilol, and only, you know, when we are very optimistic, we are thinking that 50% are responder to propranolol. It is easier to adjust and is better tolerated. But again, the challenges. It is a Cochrane analysis, and this Cochrane analysis, which included, it is published this year, which included almost all studies published with carvedilol, have shown that it is no influence of carvedilol on mortality when compared with classic non-selective beta blockers. It is an idea. Maybe we can use propranolol, and if we have a method to evaluate the hemodynamic response in patients who did not respond to propranolol, to change, to switch to carvedilol. Unfortunately, we don't have a standardized method to discover who is responding or not to beta blockers. There are some papers who have proposed different methods, transient elastography of the liver, of the spleen. Here is a paper written by Bogdan Prokopets, but I think we are far to be able to use elastography for choosing what patient is responding or not to beta blocker. And I want you to pay attention about another problem. It is a carvedilol toxidrome, which is mentioned in the literature: hypotension, bradycardia, cardiogenic shock, change in mental status, hypoglycemia, and hypothermia. And you should be aware, if you are using carvedilol in your clinics, that you should have glucagon, because the treatment, there are not enough studies in the literature, but in what I have studied, I found only this kind of treatment which can be given to a patient who have this kind of toxidrome. Glucagon bolus, 5 to 10 milligrams, and then infusion until the status of the patient is improving. So it is not easy to give even a pill to a patient with liver cirrhosis. Of course, the knowledge have advanced. Of course, we know now better the importance of portal hypertension in liver cirrhosis, and it is interest in trying to revert portal hypertension and to find if we can stop the evolution of liver cirrhosis. I have told you that I am trying to look a little bit in the future, very fast. Of course, the problems remain the same. Could prevent appearance of varices, could prevent the increase in size of small varices, could prevent the decompensation in compensated liver cirrhosis. You know probably this paper that in patients who have no clinical significant portal hypertension, beta blockers have no effect. So there is no indication for treating patients without high-risk varices. This is the paper which stays at the basis of this conclusion. It is an old one done by Grossman, but even this paper who have shown that it is no difference between timolol and placebo when the patients, when they looked again to the patients, those with the pressure gradient lower and higher than 10 millimeters, they found a difference, you see? So beta blockers in patients with clinical significant portal hypertension could have an effect and gave us hope, but they may be used to stop the evolution of liver cirrhosis. I will finish with this paper. It's not published yet. I have looked a lot to find some data about it. It is, probably Elsa can tell us more because it's a paper which comes from your group, no? I think so, from Barcelona group. Predesci study. It started in 2011, I guess. They are telling us that the paper is finished and they have very interesting results. They tried to see, it is a cooperative, multi-center, placebo-controlled, randomized clinical trial, so very hard to be done. Probably the first of this type with beta blockers. They included compensated cirrhotics, but with the gradient more than 10 millimeter mercury, so with clinical significant portal hypertension, without varices requiring treatment, and without a previous decompensation. So very interesting study. They tested for acute response to IV propranolol, and for acute responders, they put it on propranolol or placebo, and for non-responders on carvedilol or non-responders. I have asked Jaime Bosch if he tested the response to carvedilol, but he didn't at the inclusion time. Is it true? Yes? So we might know for sure if all patients included in the study were responders to propranolol or carvedilol, but it is a chance to be, anyhow, much more than in the previous studies. And he followed the patients to see any decompensating event. I don't have all the data. As I told you, I have looked a lot in the literature. There are some results on the trial, but I could find only this one for patients who have responded who were on propranolol or carvedilol, and it was assumed that they had a response to beta blockers. You can see that the first clinical decompensation were significantly lower than in those who were on placebo. I think it is a very interesting result, which give us hope that we can change the natural history of liver cirrhosis when we cannot influence the etiological factor. Because of course, when we can influence the etiological factor, this is the best way to do it. But when we cannot, beta blockers might be of use. I have looked a lot about this PREDESCI study. I hope the results will be as optimistic as this overview appears. So in conclusion, I can tell you that beta blockers are still essential medication in liver cirrhosis. Even we don't have high quality data about, we have a lot of experience, and maybe carvedilol is better than propranolol in some situation, but be aware of carvedilol toxidrome, and we still wait the data from PREDESCI, but we have a lot of hopes that we could influence the natural history of liver cirrhosis. Thank you.
Thank you very much for this nice overview of this topic, and any questions from the audience? Well, first, sorry, I cannot give you any further information about this PREDESCI study because this was performed by the people from the hemodynamic lab, and I only know these results too, so I cannot. Yeah, sure. Thank you very much. Okay, so we'll continue with the next speaker, and the next talk is about new therapeutic targets in hepatic encephalopathy by Mircea Diculescu.
Good morning. First of all, I would like to thank the organizer for inviting me to this very interesting meeting, and also to congratulate the Young Romanian Association for Liver Disease for organizing this very interesting course. So it was, sorry, how do I step back? Yes. It was a challenging subject that Liana have gave me. For me, target is a very clear idea, but I didn't know very clearly what I mean by new. New means maybe the new classification of hepatic encephalopathy. New is not very new. Maybe new cellular and molecular pathways, maybe new principle of management, and I will discuss with you the gut-liver-brain axis, which might be a very interesting topic, and also earlier targets like minimum hepatic encephalopathy, and also maybe new validated molecules. So we'll try to speak about all those things in the next few minutes. So we know that hepatic encephalopathy is a neurological and neuropsychological complication of acute or chronic liver injury, and it has a very wide clinical spectrum from slight alteration of cognitive functions to coma. I'm sorry, not from slight alteration, maybe from normal, and this is one point I would like to emphasize in my next talks. And also we have special population because an alcoholic has also alcohol in his blood maybe. Some drug abusers have also drugs in their blood, and other disease might have their own attack against the brain. It's a severe disease, and the lifespan of a patient with hepatic encephalopathy is very low. If we have only 17% in a patient with no complication of death in the first year, 64% in a patient would have already hepatic encephalopathy. The severity is also induced by the fact that the patient has to be in the hospital very frequently, and the cost of hepatic encephalopathy is very high. Severity means quality of life, and severity means also after liver transplantation, the patient should have also hepatic encephalopathy, even if he was already transplanted. Everybody of us know the West 7 criteria for diagnosing hepatic encephalopathy, but I would like to stop a little bit about the new classification of hepatic encephalopathy. And we recall, all of us, that A classification means acute liver failure, and I will have only a few slides about acute liver failure. Nothing I will say today about acute on chronic liver disease. And the middle of our discussion will be about liver cirrhosis, so I will not discuss about encephalopathy in shunts. In this slide, things might be clear. We have covert, which means minimal and grade 1, and overt, which means grade 2, 3, and 4. This might be clear. And also, it might be episodical, recurrent, or persistent. So in this slide, everything might be very clear. Unfortunately, if we are looking for the definition of these aspects, we see that it's a very, very high inter-observer evaluation between normal, between minimal hepatic encephalopathy and grade 1, and everybody is sure about 2, 3, and 4. Everybody knows how to diagnose coma in a cirrhotic. We should never forget that that might be another core of metabolic encephalopathy. We should not forget that there are drug-induced, alcohol-induced encephalopathy, and maybe do not abuse about epileptic status. So if we come a little bit back to the definition, we have episodic, we have recurrent, and we have what I would like to speak a little bit more about minimal hepatic encephalopathy. That means that there are only neuropsychological signs without maybe any clinical sign. So even this minimal, so subclinical, as we see in the right-hand side of the slide, here there are no signs, but we have to take into account of this situation, because there is an alteration of quality of life. It is a predictor of hepatic encephalopathy, clinically significant, and this will influence survival of the patient, as I've told you. So in a minimal hepatic encephalopathy, there are psychomotor slowing, attention disorder, short-term memory failures, and maybe alteration in the executive functions. And sometimes I think about myself after my first 12 hours of work, of hard work in the hospital or in my private practice. Maybe I have some psychomotor slowing, alteration of attention, and short-term memories. So this is something that might happen in other conditions, not only in hepatic encephalopathy. The clinical examination might be normal, but only psychometric tests are supposed to help us to diagnose. We must also diagnose through the discussion with the family. The patient is coming always with his wife. He looks to his wife. He has some problems with his memory, maybe some car accidents. And sometimes we have also patients with IBS, which have some sort of behavior. So this is not very characteristic. So we have to make, and then with a sleep disorder, so we have to make some tests. And the tests are portosystemic encephalopathy tests, are critical flickering frequency tests, are continuous reaction time inhibitor control tests, Stroop test, and Alpha Sigma had helped us to use the Stroop test in Romania also, and also some EEG examination, but this might be confusing by the fact that electrolyte disturbances might be important also. The consequences that they will interfere with the daily task, lower the quality of life, high risk of driving and work accidents, and risk of evolution towards overt hepatic encephalopathy. I show here that they are affecting the quality of life even minimal, and hepatic encephalopathy decreases the expectancy of life in cirrhosis. The pathogenesis of hepatic encephalopathy is due mainly to the ammonia. There are other mechanisms may be also due to the fact that we don't have a very clear differential diagnosis in those patients if they have alcohol abuse or if they are taking drugs. The ammonia pathogenesis is well known. We know that everything comes from the gut and then pass through the liver, and the kidney is also involved. The next step is the glutamine role, which is very important also, and we must think about glutamine role because it's involved also in other three positions, like in the kidney with the increase of glutaminase, and in the brain and in the muscle where glutamine synthase is involved. And this comes the new principle which is increasing in the last years, the gut, liver, and brain. Liver, gut, and brain, because everything comes from the gut, small intestine and large intestine, because even in small intestine comes the absorption of some nutrients, some amino acids. The slightly inflammation in the small intestine due to bacterial overgrowth may be involved, and from the colon comes also mercaptans and other molecules, and also the alteration of the microbiome might be important. And we have here a lot of potential targets for new drugs development in the future. We know the ammonia, glutamine, and neurotransmitters, the transformation of glutamine through glutamine synthesized in the astrocytes, and also the neurotransmission alteration. I will not emphasize on this. And there are also other pathogenic pathways which are recognized, like manganese, aromatic amino acids in excess, inflammation through cytokines, and blood-brain barrier alteration. This is a very well recognized fact, and I will give only one example about this, the importance of the brain-blood barrier, which involves other molecules and other receptors through the into the blood wall and the brain barrier. Coming back, how can we lower ammonia? And this is a standard treatment, but I will show you a little bit about some new, maybe new targets, not only new, but potential targets. The nutritional support and the branch chain amino acids, which are very important, and also how to influence the gut by laxative lactulose, we already know, rifaximin, we already know, and pre or probiotics, which might be very helpful in this situation. So the gut, liver, brain axis is involved in this. Therapy is about treating hepatoencephalic bouts. We know how we can do it, and secondary prophylaxis. It is not already recognized that primary prophylaxis of minimal hepatic encephalopathy can be reached, but it's a potential target. We know the precipitation factor. I will not emphasize on this. And the management means to identify and treat those precipitation factors, and we have to use lactulose and rifaximin for prevention of overt hepatic encephalopathy. with supportive care, identification or removal of precipitating factors, and of complication of overt hepatic encephalopathy like infection, bleeding, and dehydration, reduction of nitrogenous load, correct electrolytes, and this is very important in order to prevent recurrence of encephalopathy and to assess the patient for liver transplantation. He might die in 64% of the patient in the first year. We know already the treatment option in overt hepatic encephalopathy, like nitrogenous low arising from the gut, bowel cleansing, lactulose, rifaximin, binders of ammonia, neurotransmitter, and maybe occlusion of portal systemic shunts. Only 2 slides about acute hepatic encephalopathy in acute liver failure, so the type A. Here, not only ammonia, but the cerebral blood flow, and inflammation are involved. So ammonia is also very important, but the cerebral blood flow and inflammation are also important. So we have to make general measures, intubation, ventilation, propofol sedation in such a situation, minimal environmental stimulation, a neutral position with the head a little bit in 30 degrees elevated the head in order to lower the blood flow from the brain, and also measuring all the monitoring that we have to do. The specific therapy in this situation are already known. I will not emphasize. I will emphasize only about the high dose of L-ornithine phenylacetate, which is safe and tolerable to affect ammonia level in these situations. Coming back from the microbiome is not new. It's only 2 billion years old, but the dysbiosis in the human being is important, and the dysbiosis in the patient with liver cirrhosis is very important, and we are speaking especially about the colonic mucosal microbiome. So the microbiome which is right in the mucosa. And rifaximin can have a very important role, like cognitive improvement in minimal hepatic encephalopathy without significant stool microbiota composition change. So this is a good way. Prevention is lactulose, rifaximin. We don't know exactly if routine prophylactic is necessary. We know what rifaximin is. I will not emphasize about this molecule because we are using it in 200 milligrams on a tablet, not in the 550 milligrams like in the United States. Other ways of managing overt hepatic encephalopathy is oral branched-chain amino acids. The IV LOLA, neomycin, and metronidazole may be an alternative, but we use especially in nowadays rifaximin. I used polyethylene glycol, but only in a very particular situation. I have to check the patient for colonic cancer, and I gave him polyethylene glycol, and this have resolve also his encephalopathy. So polyethylene glycol maybe on nasogastric tube might be a solution for the patient. The LOLA means L-ornithine L-aspartate, which we are already know about how it works, but the effects might be temporary, maybe a rebound of hyperammonia, so we should have more data about this. We know also the non-ureic nitrogen scavenger like sodium benzoate, diacylorphenylbutyrate, and ornithine phenylacetate that I have already told you in acute hepatic encephalopathy. The nutritional aspects of branched-chain amino acid is important, and it is, has an important role also in the skeletal muscle metabolism. Flumazimil is only a short-term beneficial. It doesn't influence the all-cause mortality, might have 2 roles: a transient improvement in severe overt hepatic encephalopathy, which might induce the possibility of administration of treatment by mouth in order to feed the gut and the small intestine. and maybe it has a role in reverting the patient which are not recognizing intake of benzodiazepine previously. Acetyl L-carnitine can reduce ammonia and is improving the paper-pencil number connection. And about high-dose albumin, we have already found a lot of things about this. I will end my presentation with the new idea that the diet in hepatic encephalopathy is something that is improving in nowadays, and we have recent papers who are presenting that the nutritional support might be a high protein intake for the patient, so we don't think that we in all situation should recommend for the patient a low protein intake. And as take-home messages, there is a good gut-liver-brain connection, very important even if the muscle and the kidney are involved, but the gut is the production of the ammonia, which is the most important and most maneuverable mechanism of controlling hepatic encephalopathy. There are different mechanisms that can induce hepatic encephalopathy. There are many molecules that may induce hepatic encephalopathy. We must try to treat even minimal hepatic encephalopathy, and in nowadays we have not many validated new treatments in hepatic encephalopathy, and I thank you for your attention.
Thank you very much. We leave the questions for the end of the session, so I would like to invite Professor Czyżewski-Prelipchan with the next speech, coffee, herbal, and dietary supplements for liver diseases.
Before coffee break, I will present you something about coffee, herbals, and dietary supplements. The history of coffee, we know everybody that it's fascinating. The coffee, it's named wine of Arabia. And in 18th century, Bach composed cantata, a coffee cantata, which is a love story about coffee addiction. What may I say about coffee in nowadays? Each day, more than 2 billion cups of coffee are drunk, requiring more than 7 million tons of coffee beans. Brazil, it's now the leading country in cultivating and exporting coffee beans, followed by Vietnam and Colombia. And Europe, of course, is the largest consumer, followed by the United States and Brazil. From the economic point of view, we must know that coffee is the second largest traded product after petroleum. We know everybody that coffee has a lot of good effects on cardiovascular system, on metabolic system, on neurological systems. But in 1986, Arnesen published for the first time his research about coffee, and he found that coffee decreased transaminases and gamma GTP. Then it was discovered that coffee determined decreasing fibrosis, hospitalization, mortality in alcoholic liver diseases, have a protective effect in hepatic steatosis, and decrease the incidence of hepatocarcinoma. Coffee is compound about 1,000 chemical substances, lipid, vitamins, and so on. And it has more 800 volatile compounds formed during roasting process of coffee beans. The main important components of coffee, caffeine, cafestol, caveol, polyphenol, and melanoids, have anti-necrotic, anti-cholestatic, antioxidant, and chemoprevention effects, in a word, beneficial effects on liver function. we must know something, that drinking drinks with coffee, like tea, cola, and so on, this one have limited action in liver disease comparative with coffee. The most important component of coffee acts by decreasing liver fibrosis, hepatic detoxification, and has antioxidant activity. By alter the mechanism and activity of enzyme involved in xenobiotic metabolism. Consumption, more than 3 cups of coffee a day, decrease transaminases and gamma GTP, especially in men with obesity, heavy smoker, heavy drinker, and with chronic viral hepatitis. Not the same things are seen in women. These are a part of studies that prove everything I told you, studies from Europe, from United States, and from Japan. Coffee reduces the severity of non-alcoholic fatty liver disease. The possible mechanism of acting, it's an antioxidative mechanism, antifibrotic, and anti-inflammatory mechanism. Here we have some of the studies that prove everything I told you before. In chronic hepatitis B, coffee doesn't act at decreasing fibrosis. One of the possible explanations is a distinct physiopathology in hepatitis B. But in hepatitis C, coffee have a lot of good effects, from decreasing fibrosis until improvement outcome of antiviral treatment. These are studies that prove the first of my affirmations, that coffee is not associated with decreasing fibrosis in hepatitis chronic C, and the other one that proves the fact that coffee has a beneficial effect in hepatitis chronic C. In liver cirrhosis, coffee intake decreases the risk of cirrhosis in a dose-dependent manner. More than 3 cups of coffee a day for 20 until 40 years consumed decrease hepatic fibrosis and hepatic cirrhosis. More than 3 cups of coffee in all etiology of cirrhosis decrease hospital admission and, of course, mortality. But we must know, once again, I want to say you, that we don't obtain the same results with black coffee, green tea, or other non-alcoholic drinkers. Here are the studies that prove what I say you. Coffee has more than this, has antifibrotic and chemopreventive mechanism to prevent hepatic cancer. These are done by the main component of coffee, caffeine, cafestol, and caveol. These substances act at hepatocytes and on hepatic stellated cell. In hepatocarcinoma, coffee drink has a role of prevention. A lot of research told that the role is similar to vaccination in hepatitis chronic B or method of preventing hepatic C spreading. Coffee drink reduce hepatocarcinoma no matter the etiology of liver disease. Coffee intake decreases the risk of hepatocarcinoma with 40% in coffee drinkers comparative with non-drinkers, being direct proportional with the quantity and the extent of time of drinking. But this effect is more evident in person aged between 69 and 79%. In coffee, we have another component, chlorogenic acid. This substance has an inhibiting effect on carcinogenesis in hepatic cancer, indifferent of the etiology. These are a few studies that
prove us the role of coffee in hepatocarcinoma. Now, what is very important, the method of preparation. Roasting is responsible for the final composition of the coffee. The intensity of roasting is very important for the antioxidant activity. Roasting at a high temperature determines a substance named acrylamide, which have a carcinogenic property. Types of coffee. In United States, in United States, it's used especially filtered coffee. Filtered coffee does not contain caveol and cavestol. Espresso, which is used especially in Europe, contain a substance which increases the severity of liver fibrosis in non-alcoholic fatty liver disease. Here you have different beverage and the quantity of caffeine contained in it. But now we faced with the following question. We have not yet established a standard volume per cup of coffee, the content of coffee, and which is the best method of preparation in order to have the best effects, and the duration till the benefic effect appears. Days, months, years, who knows? But a coffee prescription can be a practical prophylactic and therapeutical approach because coffee is cheaper, accessible, pleasant to consume, and is effective regardless the etiology of liver disease. But in this moment, we need more studies in order to establish dose, type, and method of preparation. This is about coffee. Now, I tell you some words about herbs. I find most relevant from my point of view, Glycyrrhizida, known as a sweet root, known in China, Europe, and United States. It is known from the first surgery in China. This is the structure of sweet root, and in Japan, more than 60 years ago, was published a study which describes us that decreasing transaminases and gamma GTP when we take sweet root, we decrease inflammation and necrotic process. By variant mechanism, from decreasing permeability of cell membrane, decrease inflammation, and finally decrease viral multiplication. And from experimental point of view, it seems that Glycyrrhizida prevents hepatocarcinoma. In chronic hepatitis C, because Glycyrrhizida decreases necroinflammation and has anti-inflammatory effects, can be administered in persons with contraindication to antiviral therapy. We know that an extradigestive manifestation in HCV can be lichen planus. In lichen planus, Glycyrrhizida decrease of erosion, decrease of erythema, and number of papilla. In hepatic cirrhosis, in which we have contraindication for antiviral therapy, we can administer sweet root, and this decreases fibrosis. And in hepatocarcinoma, administered Glycyrrhizida, the incidence of hepatocarcinoma is decreasing, but a known mechanism, maybe one possibility can be decreasing fibrosis and necroinflammation. About combo therapy together with antiviral therapy with Glycyrrhizida, we cannot yet recommend this because there are not enough studies in order to prove it. This is about herbal, But there are a lot of food supplements. These food supplements are good effect on hepatic function. Antioxidant, anti-inflammatory, anti-carcinogenic effect. I look only for curcumin and silimarin. Other food supplements like nuts, like citrus fruits, like tomatoes and avocado, has good effect on decreasing, on improving hepatic metabolism, on improving diabetes mellitus, and on decreasing cholesterol. But we must know that besides these good effects, there are a lot of food supplements that have good and bad effects. I don't say nothing about red wine, but I want to say that green tea, we know very well it, and which has anti-inflammatory, antimicrobial, anti-diabetic, anti-angiogenetic, and anti-carcinogenic effect, has also bad effects. Firstly, in 1999, it was proved that in a drug named Exolyze determined hepatic injury. This drug containing, of course, green tea. And from this moment until now, there are discovered other side and bad effects of green tea, and the mechanism by which it acts, it's not very well known. Maybe direct toxicity, maybe an immunoallergic way. There are a lot of cases in the literature, and we can be very attentive when we agree with this green tea and we prescribe it. What about Herbalife? Everybody of us know Herbalife. It has various indications, especially in loss of weight. But we must never forget that Herbalife has cytolytic effects and can be administered with very attentive to patient with comorbidities. And I want, instead of take-home messages, I want to tell you, if all of this heals, it will confirm our ignorance. If doesn't, it will confirm and affirm our naivety. And the error, if it is an error, does not become a mistake until you refuse to correct it. And finally, if Liana allow me, I will invite you to a break with coffee, herbal, and dietary supplements. Thank you.
Thank you very much for this very interesting talk. Any question from the audience for this talk or the previous one?